Muy buenos días a todos y todas.
Good morning, everyone. On behalf of the Inter-American Development Bank, we thank you for being with us for this webinar called Keys to Reducing Waiting Lists in Health. My name is Pablo Ibarraran. I am Chief of the Social Protection and Health Division of the bank, and I will be with you for the webinar. In order to listen to this conversation in the language of your choice, you can tap on the interpretation icon at the bottom of your screen and choose English, Spanish, or Portuguese. Why is it important to meet today to talk about waiting lists and health? Latin America and the Caribbean as a region faces many health challenges, and I would like to mention three challenges. First, the burden of morbidity is highly representative of non-communicable diseases, and treatment is more costly and more difficult. Second, there is limited financial and fiscal sustainability of healthcare spending. And the third challenge that I would like to point to is that there is low productivity and also there's poor quality in the health services delivered to the population. Now, regarding this final point, I have a couple of facts to share with you. Between 10 and 15% of all deaths in low and medium income countries, which is most of the countries of Latin America and the Caribbean, most of the deaths are due to quality problems in services. Only 30% of avoidable deaths are amenable to health care, and 70% is associated with deficient quality of care. So when we think of quality, the opportunity in health is necessarily an essential dimension that needs to be considered. Unnecessary and long wait times are a problem. They are a problem because of the effect on people's health and also because of their effect on rising costs for operating healthcare systems. The wait means that universal health coverage, in other words, that people receive the care they need, when they need it, where they need it, becomes a euphemism. So, to work on reducing waiting times is key. And the question is, how can we do that? Today, we're going to see that the most effective strategies are those that simplify scheduling visits, improve evaluation methods for classifying clinical risk, and they provide oversight over the resources that are available for caring for the population and its needs. So the whole idea is to look at points of inefficiency throughout the whole process of patient management. Now, there are definitely problems with infrastructure. We are short on equipment, inputs, and there's a shortage of qualified human resources. These are critical structural problems that definitely explain the congestion on the demand side. But when a decision is made without clear technical criteria on how to assess risk, what patients should be treated first, and to where we should refer patients, all of that means that those items have to be tackled first. Today, we're going to talk about efficient patient management. This is a key point to improve the efficiency of the system. And we see that if changes are made in the financial system, payment methods, allocation of resources, it is possible to improve processes and shorten waiting times. The Inter-American Development Bank is committed to making progress towards universal health coverage, and we have been working with the Ministry of Health in Chile, looking for sustainable innovations that will improve the timeliness of care and reduce the time people wait to receive health care. This gave rise to a partnership with the Laboratorio de Innovación Pública in Chile's Catholic University. And here we're piloting a model, and we will be discussing that model in our discussion today. Before I get to today's speakers, I would call on you to watch a video that shows you that experience in Chile. It's quite helpful. This is the program that reduced by 70% the waiting time. Waiting lists is a problem for all public health systems worldwide, but in Chile, it had reached very high levels. Today, there are more than 2,100,000 people waiting. I work with the elderly, providing them with care, organizing activities, etc. I had a medical complication that began with a slight pain in my shoulder. I was sent to ask for an appointment in 2015, and they saw me in 2022. The Inter-American Development Bank wants to collaborate with initiatives to improve care and the quality of services delivered to citizens. The strategy is to establish a new way of managing patient care, and our challenge is, with the same resources that are available, trying to do things better. I have been implementing this model of organizing care here in the hospital. We began in 2020 with gastroenterology, where with 2 nurses, we decreased the amount of data. We had 2,600 patients going back to 2013. We first began by cleaning up the waiting list because a lot of people that were on the waiting list shouldn't have been. They have either received care elsewhere, they were no longer interested in receiving care from us. So only when the patient said, yes, I want care, did we begin to schedule their first appointment. The idea was to get them in to see a specialist as soon as possible. The exams that they had 5 years previously obviously were not valid today. So we had to also assure that the specialists could resolve these cases. Also, we have received financing through the office in Chile, and I think that this project is very easy to implement in other medical services and other hospitals. So this requires a lot of flexibility, a lot of communication, regular meetings, and the key is coordination. And it's very inexpensive because it didn't require hiring 80 doctors or buying 50 scanners. It was just investing in the salaries for 2 nurses. And we had our gastroenterologists working the same number of hours, but we were able to reduce our waiting list by 70%. And in the case of traumatology, we were able to solve 50% of the cases, and we were able to shorten the waiting list tremendously. We went from 7,000 to 700 patients over a couple of years. So it's important to have an orderly way of working. Yes, and we did this in traumatology, ENT, and this project from the viability scale was always seen as a project whose results could be shared with the entire health services network. So it is a learning process, and these lessons can be shared with the whole system. This allows us to think beyond the specific conditions in which the pilot was implemented. We see that most systems are organized in terms of what's easiest for the healthcare provider without looking at the needs of the patient. While I was waiting to be seen by a doctor, often you begin with one thing that hurts and you wind up with pain in other parts of your body because you have been trying to protect that initial injury. So it is important to think of a potential reform of our healthcare system. But in the meanwhile, before we do the reform, we can do better with the equipment and the teams that we already have. What we have to do is emphasize patient care and support the patients during the entire process.
Permítanme darle la bienvenida a
So
uno de los
allow me to welcome Dr. Alvaro Núñez. He is one of the main players in this process. He is a physician from the Universidad Mayor in San Andrés, Bolivia, and he is the head of the traumatology division of the Catholic University in Chile and a specialist in hip and pelvis. Now, Dr. Nunez is going to be talking about the characteristics of this pilot that was implemented in his specialty. So, Dr. Nunez, please go ahead and thank you for being with us today. You may be muted. Hello. Hello, and good morning. Thank you very much for this invitation. It is a pleasure for me to share with you what we have been doing here at the hospital. As you have seen, the hospital is a public hospital, and it has had to deal, just like many other hospitals in Latin America and the rest of the world, we have had to deal with ever longer waiting lists, and especially over recent years during the pandemic. As we can see here on the screen, we have this curve, the curve that was going up after the pandemic with all of the limitations that we had in patient care, not only from the surgical standpoint, as we can see here, that is a blue line, but also care given to patients that were on the waiting list. They were waiting for an evaluation or specialized or super specialized care, depending on what that patient needed coming to us from the primary health care hospitals. So to provide you with a bit of context, the Pablo Hurtado Hospital is located in the city of Santiago in the San Ramon neighborhood, and it serves three different neighborhoods, La Pintana, San Ramon, and La Granja. In other words, we have 250,000 patients in our area of service. Now, there are some special characteristics of our waiting list because this is a population that is at high social risk. It's a population where often there is a lot of crowding in their housing. It is difficult for people to access healthcare. And also often we can see that there is things affecting our patients. So we run into many barriers when we try to care for patients or manage their care. So when I became chief of this service, we were going through the pandemic, then we were in the post-pandemic, and we had a waiting list of 5,975 requests. So that meant that we were in a situation where we had to untie several knots. And these were knots that were the main reason behind this long list. First of all, we saw that there was absolutely no order in terms of the consults that went back for something like 6 years. In other words, a lot of these requests were just on paper. They had not been identified. They were not standardized in any information system, so we really couldn't establish much order. In many cases, we had the wrong telephone number, the wrong address. So you can well imagine that after so many years, the pathology is different or the patient has found some other solution. And all of that made it even harder to address these cases. Also, we, in serving so many people, had to apply the health standards in the country. So there was less um, traumatology care than what we should have had. So we had to address this problem. And here we worked with the LEAP, which is the Laboratorio de Innovación Pública, the Public Innovation Lab. And we worked with the university, always working with the hospital. It's a partnership with the German clinic and the Pablo Hurtado clinic, and also the administrative section of the hospital was involved in these efforts. So in that connection, I worked with the university, with the LIP, the Public Innovation Lab, looking at what had happened in the past. In 2019, 2020, the hospital had done some research and presented a proposal on how to do patient management. Then in 2020, 2021, where it was impossible to provide personal in-person care, there was a pilot program that had been implemented, and there was a very lengthy waiting list, as you saw on the previous slide. And then with telemedicine, it was possible to shorten the list significantly. Consequently, in view of that experience, we began to implement a pilot for traumatology. And the previous slide, please. Previous slide, go back one. Obviously, the pattern can be different because the traumatology patient is often harder to assess if you cannot do that in person. And as I've already told you, these are patients who have gone through different tests, and traumatologists need to examine the patient to establish a diagnosis, or sometimes that patient has never been examined, so there's no clear idea of the patient's needs. Consequently, we had to deal with that difficulty. So as I said, we had the support of LIP. We had a researcher and a nurse from them. Also, we had the CRS providing administrative staff. Then they too were doing telework. And later, when they were there in person, and thanks to the Development University, Universidad del Desarrollo, we had a kinesiologist who worked with us for 22 hours. And this is absolutely key to manage everything that came next. Now, what does that mean? We sort out the pathology, looking at the different limbs, the limbs that we had examined, and we began to apply protocols and standards in keeping with the patient's disease process, and we began to work with the kinesiologist. And we asked our patients, how long ago were you examined? And how could we assure that the patient could be seen with just one trip? That meant that the patient only had to travel once to make an appointment to get the test done, 1 hour with the traumatologist, one appointment with the traumatologist, excuse me. And this is a fact because, once again, I should point out that this is a vulnerable population. So going to the hospital is an issue for them. Now, this shows the process. We can see the different components of the model, and there are all these steps. First, the first step is updating the waiting list, the contact with the patient, then a reprioritization, a previous checking of scheduling and the tests that have been done. Then we have exam management before that first appointment, and then intake slot management. In other words, looking at specific exams, tests, lab tests, all of that has to do with managing our centers where patient care is provided. When we began to look at these lists, we had to determine if the patient was a relevant patient, if the patient was still alive, if the patient had moved, if that patient was still covered by public care. That's called FONASA here in our country. And basically, what we were doing was updating everything having to do with contact information. So that depended on the technical administrative staff. They made a major contribution. We really have to appreciate the support we receive from these people. So that allowed us to cull our list, to get more up-to-date information, and have proper contact information for these patients. So patient contact was done directly by the kinesiologist. And first of all, that person confirm the requirement for the appointment. Is the patient still interested in receiving treatment? If we could not contact the patient according to the standards established by the ministry, we have to try to contact them through all means. So first of all, we have to go through the primary health care provider. That is the entity closest to the domicile of the patient. And if that's not possible, we have to send a certified letter. All of this with appropriate timing and with standardized procedures according to the ministry. Then, with a strategic partnership with the OIRS, which is the Information Complaints and Suggestions Office, we were able to establish contact with the patients. Now, what I was telling you about is that with each segment, we set up an evaluation protocol. That was implemented by the kinesiologist, asking what hurts, what is wrong with you, because often a patient has pain in one limb and then wind up with some other sort of pain. Or often they have gone to see another type of doctor, or they need tests or further examination. So there was a prioritization done, and there we had two traumatologists that establish whether or not we need to refer to the primary healthcare provider or not. And if necessary, other tests, other procedures are prescribed. Also, the agenda is updated. And in terms of intake slots for traumatology, often those slots really did not lend themselves to this type of process. So we were able to reduce by 27% the intake for, or we were able to increase, I'm sorry, by 27% the treatment provided by traumatologists. That opened up 200 slots per month. So every day we would discuss with the kinesiologist saying, okay, how are things going? What is new? And this is very important when you think of the flexibility of the program, because obviously the problem that came up in week one is not the same problem that we had last week when we met. And probably it will not be the same problem when you're in the future. So you have to keep an eye on the possibility of making changes so that you can address this type of situation so as to deal with it. So all of this obviously goes hand in hand with meeting of the CRS. The CRS is outpatient consult at the hospital, and that is where the specialists, the traumatologists, are. Obviously, the whole idea is for patients to be seen once they have had their tests or have been examined, because often these lab tests, imaging tests are operator dependent because we had to coordinate special meetings to do the evaluation of scans. So we would devote one day to examining patients so that they can be assessed again, looking at the strengths. An important strength is that the patients not only were seen by a traumatologist, but also they are seen by a traumatologist that is a specialist in the subsegment for which the appointment has been made. So that saves a second appointment. That way, the patient doesn't have to come back 2 or 3 times. We're able to produce a response in the first visit, which is much quicker. Now, these are basic exams, scans, depending on the subspecialty. And as I said, the management was done by the kinesiologist. So she had a special folder so that the patients would come in, get their test that same day, that exam, and all of that in one trip, and they would go away with a solution. Now, with these strategic partnerships with the radiology service at the hospital, it is possible for the patient to go through the whole process with no major disruptions. The whole idea is to see the patient once. So this is a chart that shows you how the waiting list with 5,975 requests is down to 235. Now, this would have been impossible without the support of all of the people who were involved. I've already said that. This shows how devoted they are to their jobs, and they have been able to solve the patient's health problems. Currently, we have reduced on average, we went from 1,443 days to 103 days, and the mean is 1,358 days down to 57 days. We want to compare ourselves with some other healthcare systems, and here, and I want to be very clear on this, in terms of care, just care. We're talking about care in traumatology in our hospital. Their external care, these are our waiting times. Obviously, there are other problems that the hospital has, problems with the healthcare system in Chile, but this is what we're doing. This is what we have been able to accomplish in terms of responding to the needs of our patients. We're not talking about surgery. We're talking about the waiting list for patients that require primary care in these communities. Thank you. Next. So basically, and this is part of what we have. Of all these patients, the patients that were assessed, that were seen, 71% were served by a traumatologist. They were seen by a traumatologist, cared for by him or her. And these patients, they may have moved, they aren't at the same address, or they were cared for somewhere else or some other way. That is a small part of the population. However, not finding patients, they're not coming in, that is a reality, and it's something like 13.5% of the population. Now, of the results, the conclusions from all of this work, I think that collaboration, public and private, working with universities, the work of healthcare providers, the work of health professionals, and the flexibility with which we can work. All of this does pay off. And I think that it is the time to thank all of the people and thank all of these patients that we have been able to serve over the last few years. Thank you.
Thank you very much, Dr. Nunez, for sharing this valuable experience and describing the wonderful work done by the team and the core elements that led to these good results. And now I'd like to add Dr. Paula Bedregal to the panel. She is a specialist in public health and family medicine of children and professor at the School of Medicine of the Catholic University of Chile. Thank you very much, Doctor, for joining us. And to better place things in context regarding the experience and understanding the magnitude of the challenge faced, we would like to know your point of view on the situation of waiting lists for healthcare in Chile. And please allow me to suggest two questions so that I can guide this reflection. First of all, in your opinion, what is the importance of patient management and continuity of care approaches in addressing the problem of long waits for care? And secondly, from your point of view, what are the lessons learned from this experience that we could use in other situations regarding the optimization of waiting list management? And thank you very much for participating. Thank you very much, Pablo, for the introduction, and to the IDB, first and foremost, for bringing this issue to our agenda and to supporting this public agenda. For us, the issue of access to health services in general in Chile is a social right, and it is important to bear this in mind. It is a social right that is enshrined in our Constitution, which is our Carta Magna. And in a way, throughout time, since one gets older, and we've seen several processes that have had to do with the waiting list, this has become not only an issue that is undergoing initial stages in Chile, which was taken care of by the specialist, but nowadays it is strongly promoted by the population. As you said previously, the burden of chronic diseases that we have in Chile is very high. And so that has led our population to be especially sensitive to looking after their health problems, because in a way, in Chile, people have access to medical services. There's a survey, the CASEM survey, that shows that 97% of the population in Chile is able to have consults and appointments with doctors, with health teams to deal with their problem. The problem is not the access, but the opportunity. And it is there where we've seen pressure recently that has been quite significant, and essentially because of two issues. I would say that this issue of access, timely access, has to do with this aspect of humanity, because it is a need that people face. Having a timely access that has this other side of effectiveness, because if we arrive late, as Dr. Nunez says, we face further complications, and that in turn faces another dynamics that has to do with the efficiency of the expenditure, because looking from the point of view of the health system, looking after people that have additional complications ends up being much more expensive. So in Chile, the issue of a waiting list is something that we've been dealing with for a long time. And one of the first challenges that we had, and I believe that we've had pilots of this nature, and thanks to the fact that we've complied with certain stages. The first one was having information, and this is essential. Knowing what is the waiting list, that is essential. And this is a problem in the region, all throughout our countries, having the relevant information that has a low level of uncertainty. And I remember years ago, over 20 years ago, we received within the Ministry of Health different plates and different worksheets where they simply said how much time you have to wait for different specialties. So there was a high level of uncertainty. And now, starting a few years ago, I would say that since the end of the year 2000, we started dealing in the country with an information system that could be supported so that we could truly find out what the situation with this is. And the main focus was on the people, that is to say, the number of people. But it did not have to do with understanding what the waiting time is. And this, which seems quite obvious nowadays, is an issue. We've learned about it, and it is quite a significant gain. Chile, just to know this clearly, we have a waiting list for surgery, for surgical treatments. We have another waiting list for specialists within which we have traumatology, and another waiting list that has to do with the procedures. So there has been an effort in digitizing from the central effort all this information, which is still insufficient. It is still not of good quality. And by health services, we've seen the need for having information, as is the case of the Padre Hurtado Hospital. And this has led to the fact that many a times local information systems do not converse. And this is a lesson that we've learned, and do not communicate with national systems. And this is a huge challenge that is faced by the country nowadays. Another interesting element that has to do with waiting list in Chile as a context is we developed a national time for waiting list in 2014, from 2014 to 2018. But this plan quickly was put into question because of an issue that was very important in the country, which was denouncing by the parliament the people that had died awaiting healthcare services. And obviously, this finds an echo in mass media. It was strongly discussed in the media, and that led to a problem and to the establishment of a commission. And I was lucky enough to participate in that commission in order to review what had happened in connection with a waiting list. Because the feeling was that resources had invested. There was a platform. We had invested in having more specialists. We had built infrastructure as a result of the reform. But what was happening is that in spite of all of this, and they were even facing a preamble to what telemedicine is, but the results were not satisfactory. Were not those that we wanted to have. We had information. And also we had this problem that seemed us to believe that there were people dying because of this. And at that time, which became a lesson to the country. First of all, the issue of information is critical. Having information on waiting times at the mean, the average, aside from the list itself, the importance of cleaning up these waiting lists, because a person, if we take a look at it from the point of view of the user, can appear in 3 different waiting lists at the same time. So how do we order the benefits in order to understand the needs of the patient, not only the need for the system to take care of the list, which is what the patient needs. And something else that was very interesting was to see that there's a waiting list on procedures was completely lagging behind in the country, and it still lags behind, and it is critical to solve problems such as gastroenterology. I don't have access to an endoscopy, and that procedure, the specialist has to take care of it, and we have to see how the specialist solves it. And so another issue that continues to be a bottleneck, and that has been a learning lessons by having the information and being able to visualize this and thus be able to move forward in connection with this issue. Another important element has been accountability, because bearing in mind the fact that we do have information and bearing in mind the need faced by the state and especially by our parliament in seeing how the public expenditure was being spent as it was related to this waiting list leads us to these budgetary line items. And what they do is that every so often the ministry has to be accountable to the parliament as to what has happened in connection with this topic in order to realize how the expenditure is being spent. So this is a good lesson for the entire system to have information and accountability processes in connection with this problem. And so we've made significant progress on information, on accountability processes, but we continue to face serious problems in waiting list of what happens in advanced countries. As you know very well, during the pandemic, the situation was quite complex. What we have learned is that there are 2 things where we have to make a much more progress. On the one hand, it is extremely relevant to have additional information in the services and territorial information on what are truly the needs of our users. talking about the humanization of the waiting list, both from the epidemiological point of view as well as from the psychosocial point of view, in such a way that we can have information that would enable us to manage and bringing this to a micro level and doing it much better, and to have much more humanized services, because we usually take a look at this from the point of view of the service, what we can offer, and not look at it from the need that exists in the population. So that adjustment, I believe, is essentially an issue that has to do with the reform, but it is also an issue that has to do with the waiting list. And this is something where, in this pilot, through making it explicit, describing explicitly the path that has to be followed by the user, because in some preliminary studies, we came to realize what these psychosocial needs were. At the same time, that the epidemiological needs that can assist us in having a much more rational planning. And on the other hand, we have a micromanagement that has to do with the management of operations. If you have seen that this pilot has enabled us to understand how, through strategies that seem to be very simple, which is simply an additional resource, and that from the point of view of the resource, it is marginal, and has enabled us, in the case of the experience of Dr. Nunez and other experiences that are taking place in the country, to be better and much more important. And this is nothing new. In the world, we have scientific literature that is being produced, and even systematic reviews, where they show, for example, with the LIM strategy, this is a strategy that attempts to reduce those actions or activities that don't add value regarding the need of that end user of the service. So these strategies have shown, and this has to do a bit with what we've done here, how we reduce waiting times in several procedures. So when one takes a look at the management of operations, and when we optimize that management, it enables us, without making any major investments. Sometimes it is investments of marginal resources in the general budget. It enables us to achieve important improvements. So I believe that this is really good news, and we have to look at it from that point of view. Irrespective of not having all the resources, with those that are available and with the changes that can be small, marginal changes, we can have good management, and we can account for this triple impact that is provided by timely access to medical services. This has to do with effectiveness and the safety of the health services, and ultimately with the efficiency of the expenditure, in this case, public expenditure, but expenditure in health in general. This is by way of a comment that I'd like to share, Pablo. I don't know whether this has to do with the question that you addressed. Thank you. Excellent. Yes, of course. Thank you very much, Doctor. Very interesting. All these points that you raised are very interesting, both on the video, and Dr. Nunez and you are clearly showing that much more can be done, much better with the resources available. Undoubtedly, we will need additional resources, that there's structural issues to be considered, but we have to understand the needs of the user, besides having these efficiencies on management, which are very important lessons that we have to share. I know that there are several participants from other countries, and everybody says, in my country, we're faced with the same situation. So I believe that these are very concrete lessons that we take with us, and which is very useful. So thank you very much. For us at the IDB, the attention concentrated on the patient, a patient-centered care, and operational efficiency in healthcare is an issue that we deal with constantly. So we support countries in their efforts in order to achieve optimal performance and to obtain and provide quality healthcare and the services that are provided. And this is all something that we always push for. And in order to share this, I'd like to offer the floor to our colleague, Sebastian Bohoff, the lead specialist in health, and has worked on health policies, concentrating on innovations and medical care and the provision of services in order to increase efficiency, access, and quality of the care. So, Sebastian, would you share with us what are the main aspects to highlight from your experience as presented by the Padre Hurtado Hospital in Chile? What are the key messages that we should keep in mind regarding how to combine these two very important aspects, such as operational efficiency and improve patient experience during the care that they receive. So please proceed.
Thank you so much, Pablo, and thank you so much, Dr. Nunez and Dr. Pedregal. I first want to start off by congratulating you on this excellent work, which I think is very rigorous and also very practically relevant and doable in many of our countries. So thank you so much for sharing these important insights, and congratulations on the success for that project. As Pablo said, the issue of waiting times, the waiting list is an important issue for us and relates to several issues in the health system. It's really great in these projects that you're highlighting the issue of waiting times and addressing it as well. So thank you for the great examples. I would like to step back a little bit and give a bit of a broader framing on the importance of waiting times for health and health systems, but also give a more broad policy context, maybe of general ways to address waiting times. And then come back to this study and sort of tie it up if I can. Some of the issues that I'll go over have already been mentioned, so I'll try to come back to some of the issues that our participants here already discussed. But maybe just starting off with why waiting times and waiting lists matter in the first place. I'll quickly go over a couple of items with regards to health outcomes, equity, quality, and efficiency. And again, some of these sort of details and nuances we've already heard. I'll try to summarize a little bit what was said before. So in terms of health outcomes, we know that waiting times, by definition, really mean there could be delays in providing care to patients who really need that care. And as a result, the health condition can get worse and can lead to complications and even further costs downstream. And of course, while people are waiting on the waiting list, their health problems will persist with them, so they have to live with the health issues already. So there's both an issue of having the health problem that is not addressed, and then also the potential risk of the health problem getting worse over time. And of course, that's an outcome that we would like to avoid. I think there's interesting issues of how waiting times relate to equity considerations. Starts off that most waiting lists do not prioritize patients according to their need, who should be seen first based on their need. Often that's not an issue that is addressed in how waiting lists are implemented in our region. Of course, there's also the issue that some people who can afford it maybe can skip the waiting line and seek care elsewhere. There could be, for example, in the private sector, which has its own equity implications. If some people can leave while others do not have the choice and need to stay on the list. Then I think in some countries, I think that's a very interesting issue. There's other ways to skip ahead in the line. Countries can use the legal system sometimes to bypass their place in the waiting list to tell us other ways to accessing care. And of course, if somebody gets bumped up in the list as a result of legal action, somebody else gets moved lower in the list again. And so there's also equity implications of how we use the legal system, how we opt out of the public system to go to the private sector, and how this matters for overall equity and population health. Now, Pablo already mentioned just now in his opening remarks, quality of care, which is really a key challenge for health systems and healthcare in our region. Long waiting times are also a quality problem in many ways. Pablo just mentioned the issue of patient-centeredness. Really good quality of care means that we should focus on the patients and the patient's particular needs and serve those needs to the best of our ability. And it also means to empower patients to become active participants in their care. And waiting lists and long waiting lists in particular are really the opposite of patient-centered care. Many waiting lists ignore the individual needs. There is no prioritization, and they certainly do not empower patients to be active participants in the care that they receive and the care that they need. I think also on a higher level, on a more system-wide level, waiting lists can create issues of confidence and trust in the system. If you're on a waiting list, that often means worrying whether you get the services that you need at all and the time that you need them. And it also raises important questions of how much you can actually rely on the health system to provide for you when you're in need. And so I think on a very systemic level, this is a waiting list can also lead to a crisis in confidence and trust. And I think that's a very important point in many of the countries in our region that struggle with waiting lists for a number of reasons. Now, we already heard about efficiency. We're not prioritizing patients according to their need. That can, being on waiting lists can lead to worse health outcomes. There's inefficient use of resources that lead to waiting lists and that are a consequence of waiting lists. And I think the existence of waiting list itself also points to inefficiencies. And there's sort of low quality of care, worse health outcomes, gaps in the health system's capacities. These are all issues that are evident from having waiting lists in the first place and long wait times. So I think in these ways, waiting lists and waiting can be bad for your health. It's also bad for equity, quality, and efficiency. And they're really, waiting times are also, long waiting times are a reflection of how well the health system functions and how well the health system can serve the population. And I think that makes the issue of waiting times and waiting lists really important. Now, just briefly, just sort of a broader context on ways to reduce waiting lists in general, the policy levers, the ways we can intervene on this. Of course, it's obvious that the existence of waiting times is a result of an imbalance between the demand for healthcare services and the supply of it. But it's also, as we heard, a reflection of inefficient processes and how we match demand and supply in our existing systems. So obviously, then the general ways to reduce waiting times are to increase supply, to reduce demand, or to optimize processes and the matching between supply and demand. And I think this project really nicely illustrates a couple of those policy levers. And I'll sort of go more broadly about some ways to do this, and then come back to this project and sort of explain to you why I think this is such an interesting and excellent example. So in terms of increasing supply, of course, we can train more health workers and deploy more health workers. That's expensive and takes time. We can also rethink how we use resources that we already have. For example, we can change who provides what kind of care, is known as task shifting. Nurses can take on some of the roles that doctors maybe have provided, so we can free up some doctor time by changing the scope of practice for nurses. We can also accept our constraints in the supply of healthcare services and allow an opt-out. In fact, many public health systems in OECD countries will pay for patients to use private sector services if the wait time in the public system is too long. So in some ways, this is throwing up your hands and giving up a little bit, but it enables patients to avoid very long wait times. So this is on the supply side. On the demand side, of course, we should do better prevention, better primary healthcare services to prevent diseases in the first place and to avoid complications and diseases from getting worse. As we heard in this project, we also can allocate our health resources better, and patients to different health resources. That involves establishing the need of the patient, prioritizing, doing triage, deciding what kind of care patients really need, and then sending them to the place that can provide it as quickly and as best as possible. So this is sort of the cleaning of the waiting list example. But I think it also involves this idea, and I really think that's a great idea in this project, to monitor and to work with patients on the waiting list, to make sure that if something gets worse, that you can intervene sooner rather than just working off the list. This is to be more intelligent about how to manage the list in the first place. And I think that itself also means engaging the patients in their own care. So this goes back to this idea of patient empowerment and being patient-centered in our care. And in terms of optimizing care process, we already heard many examples. I think there's probably lots of scope. This can be very fast and can be even cost saving. And I think this study really is a great example of how to look at the overall process that needs to happen, thinking about where to intervene to just do a better job at managing the matching of demand and supply. And I would like to say that I really appreciate that your approach is not just a technical optimization of the processes, but it has a very strong patient focus. And I think that's absolutely critical, especially in the context of integrated care. So it's really in these sort of complex situations when there's a sequence for the health system to go through, but also a sequence for the patient to go through, and making sure we don't lose either the health system or the patient along the way. So congratulations on that approach. I think it's very excellent. So just to come back to the study, then I think the results that we've seen are absolutely impressive. And one would expect, this has spillover effects on health outcomes, the equity, equality, and efficiency issues. And I think your study sends a very positive message. You can look at this waiting times issue and be very frustrated with it. But I think the results of your work really show that there's huge potential to reduce waiting lists by dramatically the results that you showed us just now. And it does not need to be very complicated or expensive. It does require careful attention and to be thoughtful. And I think this your study sort of shows exactly that. And I think it's critical to think about how to design and pilot these approaches and to iterate and to improve and to really pay close attention to how this is implemented and the different actors involved, in particular, the patients, of course. So congratulations again on this really excellent work. I think it's a terrific example for the region and has already generated a lot of interest. I see we have more than 250 participants on this webinar. So thank you for your dedication and for sharing this experience and your insights today. Over to you, Pablo.
Sí, no, muchas gracias, Sebastián.
Thank you very much, Sebastian. I believe that was a wonderful placement in the context about the general debate of the challenge that this represents, because it is such an important issue, not only in management, but it is also important in terms of the perception that patients have, the people in the confidence of having trust in the system. And before we continue with the final words and thoughts, by way of a conclusion, I ask you to please fill out this assessment of the webinar. You can access this survey through the QR code that you have on the screen, and the link will be included on the chat. We have important publications that we recommend you download. We know that reducing a waiting list is a complex problem, not an easy solution. We don't have one way of doing it. All countries have this problem, OECD countries, countries in the region, with different levels of progress and health systems. We face all these different sides to it. The experience of the Padre Hurtado Hospital is that the improvement in the teams is possible, and that these new approaches is great in order to improve the efficiency in managing health services. And in this, as in many other things, where we work with people and between people, internal leadership is essential. And that is why it is important to recognize and acknowledge the work done by teams. And when they do a good job, we learned that it is relatively easy to introduce changes in process and patient management schemes, but it is also very difficult for these to be sustainable. When initiatives are successful and that it can be sustained over time, it is really worth learning about the conditions that have made this possible. And that is why it is important to learn about these good practices and the detail about the best practices. And that is why the experiences shared today were so important. So before we say goodbye, we invite you to download and consult the series of publications that we have on best practices for more efficient management of waiting list, where we discuss in detail the lessons learned and the experiences of these pilots. Also, we would like to thank once again Dr. Nunez, Dr. Bedregal, and to Sebastian for their participation in today's webinar. I hope you have a wonderful rest of the day. Thank you very much.